Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I'm Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai. Thank you for joining me for this 314th episode of the podcast. I hope everybody enjoyed last week's episode on fetal arrhythmias with Dr. Bettina Cuneo, live from the Pedirhythm XI conference. I'm sorry if the sound quality was a little bit less than we're used to hearing on the podcast. Hopefully you enjoyed the content as much as I did, and again I'd like to thank Dr. Fabrizio Drago of Pedirhythm and also Dr. Bettina Cuneo for both allowing me to play that wonderful lecture. If you have any questions or would like to reach out to me, my email is easy to remember. It's pediheart@gmail.com. This week we're going to hear a new lecture from that same conference. I think the sound quality is a little bit better this week, so I'm hopeful that you'll enjoy it as much as I did. The title of the lecture that we'll be hearing is Finally Something New, Ivabradine, When and How. And this was from a section of the Pedirhythm meeting entitled The Modern Electrophysiologist's Toolbox. And the chairs of this session were Alpay Chelikar and Eric Rosenthal. And the speaker we'll be listening to today is Dr. Christopher Janson, who's no stranger to this podcast, as we had him back a couple of years ago. Dr. Janson is a graduate of Yale University School of Medicine and completed his residency at Boston Children's Hospital and Boston Medical Center. Following this, he performed his pediatric cardiology fellowship at the Children's Hospital of Philadelphia, followed by pediatric electrophysiology at the Children's Hospital of Philadelphia. And he is presently Assistant Professor of Pediatrics at the Perelman School of Medicine at the University of Pennsylvania. I've had the distinct pleasure of working with Chris at the beginning of his career when we both were working at the Children's Hospital at Montefiore, and I'm here to say he's a delightful guy and a wonderful physician. And I am certain that you're going to enjoy his lecture on this novel agent, Ivabradine, of which he is quite the expert. And so let's move straight on to Dr. Janson's lecture on Ivabradine. And when we're done, we're going to hear a few questions from the audience, but I'll introduce that when we get to that point. And so here's Dr. Janson speaking about Ivabradine.
Thank you very much to the organizers for the generous invitation and both the opportunity to come to this beautiful city and to talk about a topic that I get very excited about. I have no disclosures. So I got inspired by the title of this recent case report to perhaps rename my talk to How to Tame the Funny Current. So today I'll talk about the mechanism of action of Ivabradine, evidence for its use in post-op jet, EAT, and then some safety data. So Ivabradine is a novel and selective heart rate reducing agent. It acts by blocking hyperpolarization activated cyclic nucleotide gated transmembrane channels, or HCN, and specifically HCN4 channels. It thereby selectively inhibits the funny current. So if you look at the action potential diagram of pacemaker cells, it reduces the slope of phase 4, which is responsible for spontaneous diastolic depolarization, and thereby it reduces automaticity. Now, Ivabradine can only access its binding site when the HCN4 channel is in an open position or open state. And this gives it the property of use dependence, whereby it has a higher effect at higher heart rates. And this makes it a very attractive therapy when treating tachycardias. Now, HCN4 channels predominate in the sinus node, and this is where they were first characterized. And as a result, initial approvals for Ivabradine relate to slowing the sinus rate. So it initially got FDA approval in 2015 to treat heart failure in adults, essentially by lowering the sinus rate, reducing myocardial demand. It resulted in reduced hospitalizations. Then received pediatric approval in 2019 for dilated cardiomyopathy indication. And much of the early clinical use was in inappropriate sinus tach. Now, HCN4 channels are also expressed in the AV node and specialized conduction system. And given the hemodynamically neutral profile, in contrast to other antiarrhythmic agents, there's been growing interest in its use for treating arrhythmias that are due to increased automaticity. And this, one of the earliest reports was by Thomas Paul and his group in congenital jet. Now, this is a recent study from adults in the AFib literature called BREAK-AF. It's a translational study and has both a laboratory arm and a clinical arm. The laboratory arm gives us some insight into how Ivabradine affects HCN4 channels in the AV node. So they performed both patch clamp experiments and mathematical models of simulated action potentials. And what they found was that Ivabradine led to a 10% reduction in spontaneous AV nodal firing, as can be seen in panel B, as well as in the graph below. So a 10% reduction in junctional augmenticity, that tells me that for JET, you can take your rate from 200 to 180. So let's talk about JET. So this was one of the earlier studies from Krishna et al. In 2019. 8 patients, and they used a dose of 0.05 mg per kg Q12. They achieved rate control in 100% of patients with a time to with a response in less than 2 hours in 7 out of 8 patients. And in 75% of patients, they used Ivabradine as monotherapy for treatment of JET. And they observed no adverse events. So they concluded that Ivabradine is a safe and effective therapy for post-op JET, and more importantly, an alternative to amiodarone. And they recommended that early initiation of Ivabradine as soon as junctional rhythm is seen may allow rhythm control before the onset of instability. Limitations of this study are that it's a single center, small number of patients, and a relatively slow JET rate. So this next study was very exciting. This is by Arvind et al. In 2021. They performed an open-label, randomized non-inferiority comparison of Ivabradine and amiodarone for postoperative JET. 94 patients less than 18 years old were included. In the amiodarone group, they received a 10 mic per kilo per minute infusion for 6 hours, followed by 5 mics per kilo per minute. Notably, no bolus of amiodarone. In the Ivabradine group, they received 0.1 mg per kg per dose of enteral Ivabradine every 12 hours. So that's double the dose of the previous study. They also had the option to double the dose if there was no response in 24 hours. The primary endpoint was restoration of sinus rhythm. They also looked at some secondary endpoints, including time to rate control and adverse events. There were no significant difference between the two treatment arms. Just note that this is a slightly older JET cohort with a median age of around 3 years old. In terms of the primary outcome, there was no difference between the two arms, so similar rates of conversion to sinus rhythm, but that's expected for JET, which runs a self-limited course. In terms of secondary outcomes, there were no adverse events in the Ivabradine group. One thing they did see is that there was a faster time to conversion in the amiodarone group, and the difference was about 1 hour. Faster time to rate control. So they concluded that enteral Ivabradine is not inferior to IV amiodarone for treatment of post-op JET, and that it's safe with no drug-related adverse events. And they said that monotherapy with Ivabradine should be considered as an alternative to amio for post-op JET. Now, there's some limitations of this study. I already alluded to the fact that the primary endpoint may be confounded by spontaneous JET resolution, and time to rate control is really the more clinically relevant variable, and that was shorter in the amio group. The other important difference from clinical practice is that there was no bolus in the amiodarone group, and that contrasts to Phil Salt's seminal study where he reported a 5 mg IV amio bolus over the first hour, and in contrast to, I think, most centers' practices. The other thing to note is that this is an older cohort, so it may not be generalizable to a neonatal or infant JET cohort. So through PACES, we've conducted a registry of Ivabradine use for tachyarrhythmias. Any patient with a tachyarrhythmia treated with Ivabradine was eligible for inclusion, and it's observational data that was collected, including dosing and patient substrate as well as outcomes. The primary outcome really related to safety, looking at Ivabradine-related adverse events. But as a secondary outcome, we looked at efficacy, which is graded as a complete or partial rhythm or rate control. And a positive response to Ivabradine was defined by at least partial control. So there are 30 patients with post-op JET treated with Ivabradine with data so far. More than half are less than 6 months of age. The JET was reported to be hemodynamically unstable in 40%. The majority were receiving some concurrent antiarrhythmic drug, amiodarone in over a third. And at the time of Ivabradine initiation, the median peak rate in JET was 170, so actually similar to the previous two studies. The median starting dose was 0.05 mg per kg per dose, so lower than the Arvin trial. And there was a positive response to Ivabradine in 87% of cases, with effective rhythm control in 37% and effective rate control in 37%. The number of doses to first effect was a median of 2, and there were no adverse events. Here's just one example. This was a patient who had a really bad case of JET, and despite 10 mg per kg in amio boluses, and despite an infusion of amio, and despite Esmol, was still in JET rates too high to pace. And so you can see where we gave the initial tiny dose. This was a neonate, and sort of in the earlier days, we gave a small dose of 0.02. That led to a brief response, but it wasn't sustained, so we redosed another 0.025, and then 90 minutes after that dose had a sustained slowing that allowed for atrial pacing. So far, the findings and limitations of this data confirms prior reports that Ivabradine is safe in the acute post-op setting and has high efficacy in post-op JET with an 87% positive response. Some clear limitations: it's observational data, there's practice variation in terms of patient selection, dosing, use of other agents, and the grading of efficacy is admittedly subjective. Now, many have raised concerns about use of an enteral agent for treatment of a post-op arrhythmia in a critical patient. And so the concerns relate to absorption. So these patients may be in low cardiac output, they may have an ileus related to narcotics or paralysis. And so there's concerns about whether or not they're going to absorb this enteral agent. And so Mark Silva actually presented this data at Pedirhythm 2 years ago, and they conducted a PK and PD analysis of Ivabradine in post-op patients. So they measured the serum metabolite of Ivabradine and its equipotent serum levels in 8 patients who'd been treated with Ivabradine for post-op JET. And what they found was that there was no relationship between dose and level. So some patients had a therapeutic level, while other patients had unmeasurable levels. And so their conclusion was that the concentration of enterally administered Ivabradine in the postoperative setting is highly unpredictable. So not something that you want to hear when you're thinking about using this drug. That being said, they found that there was an association between serum level and heart rate reduction. So when patients saw the drug, they had a response with slowing of the tachycardia. I just looked at the patients in our PACES cohort by the dose that they received, and it does appear that patients who received at least 0.05 mg per kg as a starting dose had a higher likelihood of a positive response compared to giving the smaller 0.025 dose. So to sort of summarize what I've spoken so far about in terms of Ivabradine and post-op JET, consider enteral Ivabradine for early JET, or sort of JET-like. Try to preempt the need for amio and get ahead of it before it gets hemodynamically significant. And this is supported by both Krishna and Arvin studies. Consider adjunctive Ivabradine with medically refractory JET. Anytime we're talking about ECMO in our unit, we try to get some Ivabradine in and see if we can ward that off. And non-responders may be due to underdosing and or poor absorption, and so higher doses may be needed in this setting, especially when you have the safety net of pacing wires. Okay, let's move on to EAT. So what is the electrophysiologic basis for Ivabradine and EAT? This is a recent paper by Bruce Gelb's group, and they created the first human-induced pluripotent stem cell model of multifocal atrial tachycardia. So they created stem cells that harbored pathogenic HRAS gene variants that had been isolated from patients with Costello syndrome and multifocal atrial tachycardia. They then derived atrial cardiomyocytes from these stem cells. And these mutant atrial cardiomyocytes exhibited enhanced authenticity with higher heart rates compared to controls. One of the observations among many was that these mutant ACMs had an increased expression of HCN4 channels. And treatment with Ivabradine, as shown in this figure, led to a significant heart rate reduction in mutant ACMs. So this led me to wonder, do similar changes such as upregulation of HCN4 channels occur in other atrial tachycardia phenotypes, such as idiopathic focal AT or postoperative AT? Another question is whether EAT cases represent intrinsically abnormal HCN4 channels. This study characterized a gain-of-function HCN4 channel in a family with inappropriate sinus tachycardia and complete penetrance. They modeled the mutant HCN4 channels and found that they had increased funny current. And as shown in this figure, the degree of increase was higher in the homozygous state than the heterozygous state. When they investigated the mechanism, they found that this wasn't due to upregulated expression, but rather it was due to change in the voltage gating of the HCN4 channel, with a shift in the activation curve to a more depolarized membrane potential. So the mutant HCN4 channels had a higher frequency and probability of being in the open state. And this is all shown in this figure here. Now these mutant HCN4 channels were still sensitive to Ivabradine, as can be shown in the figure. And so they treated those affected family members with Ivabradine and observed a mean heart rate reduction of 14%. And the affected adult family members who all had tachycardia-induced cardiomyopathy had reversal of the dysfunction with treatment. So let's look at the data on EAT and Ivabradine in the pediatric population. This study of 28 patients includes 7 pediatric patients, none of whom had congenital heart disease, about just under half of whom had failed beta blocker, and 2 had failed amnio. And they developed a protocol for Ivabradine monotherapy. The dose was 10 milligrams BID for adults, which is notably higher than what's the published recommended max of 7.5. And the pediatric dose was 0.14 mg per kg per dose, Q12, which again is much higher than any of the other studies I've mentioned. They observed a 64% positive response to Ivabradine with rhythm control in 17 and rate control in 1. And the mean time determination from the first dose was 4 hours. Also, there were no adverse effects. And one interesting finding when they compared responders to non-responders was that an atrial appendage site of origin of the atrial attack was a predictor of response to Ivabradine. So that makes me wonder if there's a relationship with HCN4 localization and anatomical site. They suggested this protocol for treatment of atrial attack and concluded that a trial of Ivabradine should be considered in all patients with an incessant focal AT and structurally normal heart. And if there's no effect within 12 hours of initiation or after 2 doses, then you should stop. This next study by Huang and colleagues in Dallas looked at Ivabradine for treatment of atrial tachycardia in patients with congenital heart disease. There were 15 patients with a median age of 7 months, 80% of whom had complex heart disease, and just under a third of whom had ventricular dysfunction. Their dosing was the 0.05 mg per kg, which is the more common dosing utilized. And they observed rhythm control in 80%. And this was defined as restoration of sinus rhythm within 24 hours of starting. The failure was more common in acute post-op arrhythmias, leading them to wonder whether non-responders reflected a mechanism of atrial attack that was not automaticity, but rather micro-reentry or triggered activity. They did observe bradycardia very commonly, just under half. but this only led to discontinuation of Ivabradine in one patient, and no patient needed to be paced temporarily due to symptomatic severe bradycardia. Now looking at the PACES data, there's 14 patients with an acute post-op AT treated with Ivabradine, of whom just under half were less than 6 months of age. Starting dose again, 0.05, a 71% positive response, no adverse events. And there were 33 additional atrial attacks, not in the acute post-op setting, slightly older cohort, and more likely to have structurally normal hearts. And 24% had tachycardia-induced cardiomyopathy. Similar starting dose and 64% positive response, no adverse events. Putting all the atrial attacks together, there's 47, response rate of 66%. Now, of patients who responded, just about half were continued on Ivabradine after discharge. And just to comment that one patient in the registry couldn't get approval by the insurance company. So I mention that because it's something I've heard from colleagues and sort of motivate us to, the more we write about this, maybe we can get some insurance companies to approve it. This is a recent example, teenage Fontan, who presented with an incessant EAT and ventricular dysfunction. And we went with Ivabradine as first-line therapy. And you can see the decrease in the heart rate slope after dose 1, and then a more significant decrease after dose 2. And so this was a nice response. This was another example. This patient had more of a picture of salvos of EAT, and you can see that the blue arrow denotes her first dose, and by day 3, no salvos of EAT. So I'm going to go back to the BREAK-AF trial that I mentioned at the beginning because it brings up another potential mechanism for rate control in atrial tachycardia. So in the clinical arm of this study, in the clinical arm of the study, they randomized patients to ditch Ivabradine, and the mean daytime heart rate decreased by 11% in the Ivabradine arm. So is there a chromotropic effect of Ivabradine on the AV node? So just for EAT, consider it as primary therapy for incessant AT, especially if you have an atrial appendage origin. Consider Ivabradine for EAT refractory beta blocker before escalating to a class 1 or class 3. Consider it in tachycardia-induced cardiomyopathy. I'll just zoom through the safety data. Of 94 patients so far, just one adverse effect. And some have raised concern for potential QT prolongation. So again, from BREAK-AF, in addition to the funny current, Ivabradine inhibits IKR, but this effect was more pronounced at low heart rates. Now, amio, Ivabradine is hepatically metabolized, and amio is a CYP3A4 inhibitor, and so this is a potential interaction. Just some quick practical suggestions. You can always start with a small dose and redose if you don't see the effect you need. Keep in mind the gut absorption issue. We've dosed at Q8 hours occasionally on the inpatient side if the response doesn't persist. Pacing wires is a nice safety net, but doesn't appear necessary. And what does the future hold? What I'm hoping is that we'll define substrates most likely to respond to Ivabradine. Can biomarkers like AT4 transcripts guide patient selection? Will we be able to correlate the anatomic origin of Ivabradine responsive ATs to anatomic sites of HTN4 expression? I'm hoping we can define optimal dosing, whether that's by measuring a commercially available drug level, a prospective trial for post-op jet, IV Ivabradine, hopefully it's on the horizon, and are there, with the dramatropic effect, are there other potential targets like brain transmutation? So to summarize, when it works, and when it doesn't work, no harm, no foul. Thank you for your attention.
I hope you all enjoyed Dr. Janson's lecture to us on Ivabradine. This is a novel agent that I think will develop to be a very important agent for certain types of arrhythmias, as Dr. Janson has explained. At this point, I'm going to play a couple of the questions from the audience and Dr. Janson's answer, as I thought they were quite interesting. So I hope you enjoy this brief back and forth between Dr. Janson and a few members of the audience at Pedirhythm XI.
Beautiful talk, Chris. Now, when you're giving the small doses to infants and neonates, are you using a special commercial mixture, or are you compounding the tablet somehow? Because our pharmacy says it doesn't really disperse very evenly, and that it's sceptical it's safe to do so.
Yeah, I think nowadays we have the 5 mg per 1 ml, preformed solution, but in the early days they were doing crush and suspend, and it was a bit difficult.
Any other questions? Yes, at the back.
So, first, great talk. I question, so in terms of dosing, it sounds like, as you said, more doses, better. Have you thought about doing, has anyone developed Q8-hour dosing? Because, I think in the neonates, we could wonder if metabolism is faster. Does anyone want to whether you just go, faster? As you say, if you do 2 doses and you don't get an effect, that might be enough. Has anyone looked at, in the registry, Q8-hour dosing?
Yeah, there's a couple cases of Q8-hour dosing. We've done Q8-hour dosing in a few cases, and it's been safe. It's for cases where you have an early response and then the tachycardia kind of warms up, and we just dose it early. Particularly like a post-op jet, if that happens, I think it's reasonable to redose it early.
Well, one of the most dramatic effects we had was a newborn with congenital jet, and instead of starting at 1 per kilo, was given a 10-fold overdose, immediate sinus rhythm, and beautiful response. But I'm not advocating that. But clearly, there's a dosing issue that needs to be attended to, and we've had 1 or 2 discharged on TDS dosing.
Well, I hope you enjoyed this conversation and discussion about Ivabradine. I'd like to thank Dr. Chris Janson for giving me permission to play this lecture on Pediheart, and I'd like to thank the organizers of Pedirhythm, particularly Dr. Fabrizio Drago, for the kind permission to allow us to play this interesting conversation about Ivabradine this week on Pediheart. To conclude this 314th episode of Pediheart Pediatric Cardiology Today, featuring Dr. Chris Janson of Children's Hospital Philadelphia speaking about Ivabradine, we remember the great American soprano Jessie Norman, who died 5 years ago in late September of 2019. Ms. Norman was an absolutely gigantic figure in opera, and her voice was once described by the New York Times as, quote, a grand mansion of sound. She sang throughout the world, with the beginning of her career in Europe, but eventually she became a favored singer at the Metropolitan Opera in New York City and throughout the world. And today we hear her sing Delilah's aria from the opera Samson and Delilah by Saint-Saëns, entitled Mon cœur s'ouvre ta voix. Thank you very much for joining me for this episode, and thanks once again to the organizers of Pedirhythm, as well as Dr. Chris Janson, for allowing us to play this lecture today. I look forward to seeing everybody next week when we review the latest literature.
Dico